So we already talked about the purpose. This is to change our practice to scientific and more with support with more clinically relevant research. So the journey from evidence-based medicine to evidence-based practice. So evidence-based medicine primarily involved physicians and focused on the treatment aspect of the medicine. But right now, then it was later adopted by other healthcare professions under the term evidence-based practice. So it was started as evidence-based medicine, now it is evidence-based practice. So everybody in healthcare using the term evidence-based practice. So earlier, one of the presenters said our patient's issues are complex now. So we do need a multidisciplinary approach. Do you remember she was explaining about mother and baby, and now the mothers are having other comorbidities, maybe diabetes, overweight, maybe some other issue. So it is beyond just taking care of the mother or baby. So we need a multidisciplinary approach. What if and she also mentioned about postpartum blues and somebody harmed the baby after having the baby. So it needs a multidisciplinary approach. That means sometimes we have a mental health provider there, sometimes a social worker there, sometimes physiotherapist, when we need pharmacists there. So it's a multidisciplinary approach to solve the complex issues of our patients. It includes nurses, clinicians, nurse practitioners, physician assistants, physical occupational therapists, the list go on. And it also includes many facets of health, such as etiology, prevention, diagnosis, treatment, and more. So evidence-based practice is the key to deliver the highest quality of healthcare and ensure the best patient outcome. Evidence-based practice is always to make the best patient outcome, okay? A lifelong problem-solving approach to clinical practice, and it integrates search, critical appraisal, and synthesis of the most relevant and best research evidence. So even if you forget everything, I want you to remember that graphics. So it says best scientific evidence combined with the patient's values and clinical expertise of the clinician. Why is it important? Clinical expertise of the clinician. You have good evidence, and the patients, want to have a change. You want to improve the outcome. But if you don't know how to do it, then it doesn't help anybody. So that's why we have to train the clinicians to make a change using the evidence-based practice models. So there are 4 main aims for evidence-based practice. One is improved patient experience. The second one is improved outcomes, cost reduction, and it also empowers clinician satisfaction. Patient experience, so staying at the hospital, we do a lot of patient satisfaction survey. That is, we are not measuring the patient outcome when we do patient satisfaction survey. How was your experience staying at the hospital? Okay, so patient satisfaction is very important, and improved outcomes. Maybe they got discharged in within the time frame, but if the experience was poor, then that will affect the patient satisfaction score. So when we have accreditation agencies come, they always look at the patient satisfaction score. That's why the patient's preferences and values are very important. Cost reduction. If you are following the scientific evidence, or if your practice is evidence-based, there is automatically a cost reduction. For example, for infection control, if you are following the latest evidence out there, definitely infection is controlled. That might reduce the number of days the patient stay at the hospital. Okay, so there is a cost reduction and empowers clinician satisfaction. When the patients are satisfied, the nurses or clinicians are also satisfied. When it goes both ways. Okay, when we are happy, we take good care of patients. When the patients are happy, we feel happy also because we did something to make a change in that patient. So, what is evidence? How many of you have done a research class? No one? Not yet? Maybe not yet. So research evidence is systematically collected facts. It's a foundation for sound nursing and healthcare. And even master's prepared nurses or DNP prepared nurses, you have to have knowledge about research. How do you create evidence? So if you have paid attention in the morning when Dr. Punitha ma'am was explaining about the curriculum, there was a course called statistical. Did you see that? There was a course on statistics because the DNP prepared nurses, you should be able to read and understand statistics. Statistics is always a bunch of numbers, right? Someone has to interpret it for you. So for nurses, when you're doctorally prepared, you should be able to read and interpret the scientific literature. So all those courses that was listed and talked about this morning, that is very much needed to prepare you to be a leader and teach you, learn how to do evidence-based practice. The components of evidence-based practice, we are talking about evidence. So there are external evidence from research and evidence-based theories, and then there are internal evidence generated from outcomes management or quality improvement projects, or patient assessment. Then we also have patient preferences and values, and these are components of evidence-based practice. Evidence-based practice. So why EBP? Earlier we talked about the quadruple aim. There are 4 aims for evidence-based practice, and I tried to explain that also. Best patient outcomes, reduction in healthcare cost, reduction in geographic variation in care, that means standardization of care. When Dr. Lee presented the quality improvement, and she mentioned standardization of care. So whatever care is given in this hospital should be similar, the next hospital also standardized. So if you have evidence-based practice, then standardization is easy because everybody is looking at the same evidence. So promotion of retention of healthcare workers. So promotion of retention. Retention is in United States, it's a big, nurse turnover is a big issue. So people don't stay for long because based on some of the factors. And even the new graduates, there is a higher number of nurses leaving the bedside or leaving nursing the first 2-3 years because they couldn't take the stress. So, and also nurse-patient ratio is very important to keep the nurses happy. And then despite these benefits, how many benefits we talked about? 2, 3, 4? I said quadruple aim. All of you are here, sleepy? Okay, so we talked about 4 aims, right? So despite these benefits, familiarity and implementation of evidence-based practice remains low, okay? So it's beneficial, we know the benefits, but implementation of EBP remains low. So that is another reason we need to prepare our nurses to carry out evidence-based practice projects. That's why we need DNP, prepared nurses. I'm not saying that it is not important at bachelor's level. At bachelor's level also, you should be practicing, you should be doing evidence-based practice. Master's level also, you should be doing evidence-based practice. The difference is the DNP is prepared to translate the research from the book to the bedside. The others should be able to read and understand evidence-based practice and follow it. So I have a picture here, it says magnet, that's one of the accreditations for the hospitals. So it's a big deal if you're a magnet status hospital, that means your practice is evidence-based. Steps of evidence-based practice process. It starts with the picture and the writings on the other side, it says the same thing. So cultivate a spirit of inquiry. It starts with the 0. And then number 1, I will explain each one of these steps in the following slides. Ask the burning clinical question in PICO format. Search for and collect the most relevant best evidence. Critically appraise the evidence. Integrate the best evidence with one's clinical expertise. Evaluate the outcome of the practice decision or change based on evidence. Then disseminate the outcome of the EBP decision or change. So step 0, cultivate a spirit of inquiry. I think morning also someone asked, do you have a why question? Do you have a why question? What is your why? When you are at the bedside, have you ever thought about what is the best way of doing this? Or I wish I can do it in a different way. Have you ever, anybody has thought like that, or everything is perfect? If you're saying everything is perfect, then there is no need for all this. So there are some deficiencies. Maybe you don't want to open up and tell. There will be some deficiencies. So what is your why? Why questions, okay? And ongoing curiosity about the best evidence to guide clinical decision making. Ongoing curiosity. That means how do you have to read. You have to read scientific literature, then you will know what is out there, what is the best evidence. Then willingness to question current practices. So sometimes it's not the willingness to have the courage to ask question the current practices. That is step 0, cultivate a spirit of inquiry. What is your why? Think about a why. Have you ever wondered why something is in a certain way, okay? So how can we do it? If you have an evidence-based practice culture, if the culture is supportive, then you will have the willingness or the courage to ask that why question. So what we have to do, develop nurses who possess a spirit of inquiry within a culture that support a systematic process for asking clinical questions. So what is a EBP culture? If the institute does not have a evidence-based practice culture, then it is very hard to implement evidence-based practice, okay? So EBP culture, have knowledge about the practice to see the deficiencies. You have to know enough to see the deficiencies. Have a habit of reading scientific literature. Attend conferences, constantly have a desire to change what is not ideal. So in order to do that, you have to know what is ideal, right, to make a change. At least even think about or have a why. You have to know what is ideal. Education and, so there is always a education and practice gap. I have heard my students tell me, oh, this is how we learned in the simulation lab, or this is how we learned at the school. This is how we did the checkoff. But when we were at the hospital, they were doing something different. Or like maybe the nurses were cutting corners, like want to finish everything so quick and the student is observing everything. So there is always an education and practice gap, because what we are teaching is the ideal situation, but sometimes when you in the practice you see you don't see what you learned in the textbook. That means there is an education and practice gap. There should be a why question. Okay? Even if you won't be changed something right at that moment, take it to your faculty. You should ask a why question, why it is different. Maybe they don't have enough resources, maybe they don't have enough time. So have why questions. So ask where you feel comfortable. Ask your faculty why it is done in a different way. So another way to prepare nurses is in service to all practicing nurses, give them some, if they don't read the scientific literature, have a journal club or something, so we can talk about the latest research pertaining to that unit or population. So then step 1 is asking the burning clinical question in PICO format. I don't want you to forget PICO format, P-I-C-O-T, okay? P stands for population, and population can be a unit population, or population can be adult, or sometimes, women or men, but narrow it down, like in a trauma unit, a 5-year-old respond to treatment is different, maybe different from a 70-year-old respond to treatment, right? So you cannot say trauma patients in the trauma unit. Maybe you have to have a little bit more, narrow it down a little bit more, maybe based on the age. Or if I say pediatric population, for me, pediatric population is 0 to 21. How about 21 react to some medication? Probably different from a newborn. Or the procedures we do to a newborn may be different from the way we perform it, may be different from for a 16-year-old or 18-year-old. So population learn to narrow it down, but don't make it too narrow. So intervention, what does intervention mean? Something that you are doing to improve the situation, but this in EBP, intervention has to be based on evidence, okay? So intervention has to be, so how do you find the best intervention? We'll talk about it in the next slide. So sometimes intervention can be pharmacological intervention. I'm talking in general. Sometimes it's non-pharmacological intervention. Sometimes maybe health education is an intervention. Sometimes maybe delaying something is an intervention. But whatever it is, it has to be based on sound evidence, okay? Then C is comparison of intervention. We all have, every unit have a standard care. That's how you do things usually. So whenever you're doing intervention, you compare the patient outcome when you were providing the standard care, and now you are doing some kind of intervention, and then after the intervention, what is the outcome? So I've been learning about this NPCC program for last couple of days, so I do hear a lot of good comments on how efficient and competent the nurses are, the NPCC graduates are. So I've been hearing this. So for that, the outcome, how do we compare before and after? So before having this the critical care nurse practitioners in the unit, before having this program, how was the patient doing? What was the number of days the patient stayed in the ICU, or number of days the patient stayed intubated? Okay, then you implement this program. The standard care was the nurses were doing the standard care before. So when you implement this critical care program, after 6 months, you want to evaluate to see what kind of impact this critical care nurse practitioners made. Did you understand that? Have you compared? There was a standard practice, then you do the intervention, then you compare to see what kind of impact, what is the outcome, okay? So when you write the outcome, you have to define. So if I write number of stays at the hospital, before and after, if that's what I like to measure, then I have to have a conceptual definition and an operational definition. Conceptual definition is, what is your definition of number of stays at the hospital, okay? And operational definition is, how are you planning to measure that? How are you planning to quantify it? Did you all get the difference between conceptual definition and the operational definition? Yes? No? Okay. Then time. How long was the intervention? Okay, so for this NPCC program, maybe 6 months after implementation, after 6 months you wanted to see the outcome, how it has improved, okay? So everybody got PICO, P-I-C-O-T, PICO? So we ask PICO question when we do evidence-based practice, okay? For research, if you're doing research, then we ask a research question, okay? So step 2, search for the best evidence. I don't know what kind of search engines you use. These are the common search engines we use: PubMed, CINAHL. If there is just nursing related, you can find everything in CINAHL, that is Cumulative Index of Nursing and Allied Health Literature. Then Google Scholar, we use that too. And ProQuest is a collection of dissertation, right? Okay. Medline, yeah. Medline, PubMed. If it is like generally medical issues or problems, then Medline and PubMed helps. If it is very nursing specific, then CINAHL helps. And, you don't have CINAHL, okay. And if you have ProQuest is a collection of dissertations. So if you want to look at the dissertation, then you can use CINAHL. K-Hub? Oh, okay. We don't use that. Yeah. Then there is another one for the Cochrane collaboration. The Cochrane collaboration is collection of systematic reviews. Maybe for critical care in nurse practitioner program, maybe you can search Cochrane collaboration. So if you don't, I don't know whether you have Cochrane collaboration subscribed. Okay. So. Oh, okay. So Cochrane collaboration is good from a nurse practitioner. So I do use Cochrane collaboration a lot. So what happened in Cochrane collaboration, systematic reviews, it's a collection of systematic reviews in simply saying, instead of reading 50 articles, I can read one systematic review and find an answer. Okay, for evidence-based practice, there is a slide talking about level of evidence. So we prefer to see systematic reviews. What does it say? Because we have done enough studies with whatever problem or concern you are looking into. So if there is a systematic review, plenty of research done on that matter, on that practice concern. And everybody use Google, right? It's not regular Google, it is Google Scholar. So when you do literature review, this is a template, literature review matrix template. When you do, these are the steps for literature review. Select a topic. Select a topic, identify appropriate places to search that I showed you in the last slide. Then search for sources, read, analyze, critique, write the review. So if you look at this template, I don't know whether you can see it. So I will have, if you are doing a evidence-based practice project, it's good to have, even if you're doing research, it's good to have a literature review matrix template. What it does, if I complete the template appropriately, then after that I don't have to go through all my articles every time I think about writing, because you're not going to write your evidence-based practice proposal or the report in one sitting. It takes months to complete it. Okay, I don't want to discourage you, but that's how it is, because it's a capstone project. It takes, for your curriculum, it starts from, I think, the evidence-based practice seminars, that's where it starts, and it goes all the way to your graduation. So it's a long process. So as you go, you collect information and complete this literature review template. So you only have to read the literature review template when you sit down to write, or when you have to have a summary of what you have done. So literature review does not, I was explaining how to do a literature review, what are the search engines you can use. Then you have to have keywords, key terms to pull up the literature. Sometimes if your key terms are too broad, it will bring like 5,000, 6,000 articles. So you have to have, just like you have sample for criteria for sampling, you have to have criteria for literature review also. What year you want to see? Like you want to see all the way from 2010 till here. But one thing is, with the literature review for evidence-based practice, it's hard to find it will be hard to find systematic reviews within last 5 years. So you have to go further back sometimes to see all the research that was done in your particular topic. So, and also literature review for EBP, it is not an annotated bibliography where you describe each research in a paragraph. It is not that. It is summarizing it. After you read 50 articles, what does it say? How many of it support your intervention? How many of it doesn't support your intervention? So we want to see a good synthesis of the literature, okay? So there is a little bit about Cochrane collaboration. It was founded in 1993 and named after British epidemiologist Archie Cochrane. So what led him to do all this? Because he said, most treatment-related decisions were not based on clinical evidence. He proposed that researchers should collaborate internationally to systematically review all the best clinical trials, specialty by specialty. So this is the logo for Cochrane collaboration. It's an international not-for-profit and independent organization. I heard from your dean that you do have Cochrane collaboration, so I want all of you to go search, look for something. I do use Cochrane collaboration if I have a question about the treatment or the latest guideline. I still look Cochrane collaboration to see what is the latest asthma management guideline, or what is the latest antibiotics for certain conditions. So Cochrane collaboration will give you a systematic review. And so instead of reading all different articles, I can just get the information from reading one or two systematic reviews. I just added that for your information. So resources for evidence-based practice, systematic reviews, clinical practice guidelines. One example is asthma guidelines. For every disease, there is an algorithm that you have to follow for, how to manage it. So for critical care, maybe like how to intubate a patient, you have to follow some kind of criteria, right? You cannot just intubate anybody and everybody, right? So then there are care bundles. There are set of interventions for complex issues. For diabetes, diabetes comes with a lot of other comorbidities like, food care issues. There are other issues with diabetes. So care bundles, these are the resources for evidence-based practice. Then critically appraise the evidence, rapid critical appraisal. Are the study results valid? See, when you go to buy something, you have a lot of, for example, I see mostly women here or ladies here. So when you go buy a sari, you have like 50 of them on the table. Then how do you pick the best one? Because you have some kind of criteria in your mind, right? Then it's like it has to be cost effective, it has to be good, whatever you have in your mind. So just like that, you have like 500 articles in front of you, and so I usually do read the abstract and then see which one is best. And also, best means, is it valid? Is it reliable? Or if they have used instruments to do research, or the instrument, what is the validity of the instruments? What is the reliability of the instrument? What is the sample size? Any indication that the statistician manipulated something so they can, or the researcher manipulated something so they can produce the intended result. So you have to do a rapid critical appraisal before. What did I do? Where was I? Okay, we were talking about critically appraising the evidence, rapid critical appraisal. So for evidence-based practice, include only the studies which is valid and reliable. So this is the level of evidence I was talking about, hierarchy of evidence. Level 1, systematic reviews or meta-analysis of randomized controlled studies. So level 2, randomized controlled studies. Then controlled trials without randomization, case control and cohort studies. So when you do the literature review matrix, you can see each article what level it is, okay? For evidence-based practice, it's better to have level 1 and level 2 articles, okay? Because you don't want to make a practice change based on a qualitative article or few qualitative studies. You should be able to see the research, where they can quantify the evidence. Okay. So step 4 is integrate the best evidence with clinical expertise and patient preferences. This is the implementation step. So far we were planning. So after your evidence-based, after your literature review, you should have some guidelines from the evidence to address your practice concern that you identified. Everybody understand what is a practice concern, right? Practice concern is something that you like to change, okay? Or practice concern, there are guidelines, but the unit is not following the guidelines, then it becomes a concern, okay? So step 4 is the implementation step. So EBP is not based solely on research and published evidence. Patient histories and circumstances also you have to take into consideration. And availability of resources must also be considered. You have this evidence-based, all kinds of evidence, and you have guidelines developed, but the resources, if money is involved, if the resources or the personnel, because that is also resource. If you don't have enough staff nurses to, help you with the implementation, then that is not going to happen. So availability of resources must also be considered. So before you start the project, you analyze the situation. What is the culture of your unit? What is what kind of resources are available if you want to make a practice change? So then for implementation, the theoretical framework. Theoretical framework is the roadmap or for the process of implementation. If you're making a house, it's a blueprint, how you're going to build the house, okay? And in the morning, we looked at several theoretical framework for quality improvement. Do you remember any one of those? Have you heard Six Sigma, Lean method? Okay, so that was for quality improvement frameworks. Okay, so I'm talking about there are theoretical framework for evidence-based practice too. I did not include an example. Later, Dr. Joseph will be talking about the theoretical framework. Then evaluate the outcome. Remember from the PCO question, O stands for outcome. So you have to remember, you have to have a conceptual definition and an operational definition, because you have to know what you are measuring, how you're planning to measure. So the outcome must be predetermined and measured appropriately after implementing the EBP change. So before the implementation, you have to have a plan, how you're planning to measure the outcome. Outcomes must be measured, and it can be short-term or long-term outcome, and there is a project and process evaluation. So for evidence-based practice, it's not research, but we do research, but we do use some research methods for analysis session, okay? For outcome analysis, we do use statistical methods. For quality improvement also, we do use statistical methods. So don't think because we are using statistical methods, it is research. It is not research, it's different from research. But we are using same analysis process to evaluate the outcome. Step 6, disseminate the outcome of the EBP decision or change. You did a wonderful project, but if no one is, if it is not published or presented, no one knows about your project, okay? No one knows. You spend a lot of time to do the project, and it helped many people. So if you confine it to yourself, nobody is benefiting from it, okay? Even if it's a literature review, publish it. Even if it's only a literature review and you develop some guidelines from the literature review, it is still worth publishing, because someone else don't have to do the same literature review to come up with the same conclusion, right? So presentations at the hospitals, and our students, the master students, they present the proposal at our Sometimes during, it's a poster presentation, they do it during graduation ceremony, or sometimes we have honor society meeting, they do presentations there. Or during COVID time, it was so hard to coordinate, so they did it for the Zoom presentation for whole faculty and students. So presentation at the hospital or even the school is fine. Publications, and there is also a gap exists. We do research, but we don't publish everything that we are doing. That's a dissemination of the outcome of the EBP decision. So barriers and facilitators to evidence-based practice. Remember, there should be a spirit of inquiry. Sometimes, we don't even, cannot even focus on the spirit of inquiry because, there are a lot of barriers. But the barriers are time constraints. You have, the patient staff nurse ratio. You don't have enough time to finish what your assigned work. Time constraints. Inadequate staffing, the same thing. Cost and lack of resources. Lack of teamwork. Everybody has to, our dean usually say, you have to play in the sandbox together. Then only, that's teamwork. You're doing the same thing too. You have the common goal, so you're playing together. Then organizational support is very important. Facilitators, leadership, and champions. So sometimes, in order to have evidence-based practice project, we have to have EBP mentors or EBP champions. Then well-designed strategies should be there, protocols and resources, adequate services and resources, and time. Time is a major factor. You have to have enough time to carry out what you want to, carry out the evidence-based practice project. So strategies to eliminate barriers to using evidence-based practice. How can you eliminate the strategies? How can you eliminate, we talked about time constraint, patient-staff ratio. So how can we eliminate those barriers? You have to talk to people, right? You have to talk to the in charge or whoever is. When you become a leader, you see if you have adequate staffing so we can carry out the evidence-based practice project. Developing a strategic plan to create a culture and environment that fosters evidence-based practice. Dispelling misperceptions about evidence-based practice. So educating the staff is very important because you want them to be on your side. Then only you can do something in the unit, right? So educating. So sometimes when you know why we are doing, then they will be on your side. Sometimes if they are part of the project, if they are part of the planning, then they will be on your side. So you have to, before implementation phase, you have to assess your unit. What is the climate? What is the culture? Is it supportive? Or what are the barriers? Then you think about strategies to overcome the barriers. Then encourage questions about currently used clinical practices. And then only they will know is there any concern about the current practice. The last one is developing EBP mentors. So that is the steps in evidence-based practice project. Then do you have any? Okay, now it's time for questions. Did you learn anything? You don't have an answer for anything? Do you have any questions? If you don't ask me questions, I'm going to ask you questions. No questions? What does PICO stands for? What does P stand for? What I stand for? C, comparison. Outcome. Huh? The time. Very good. So under outcome, I talked about two definitions. What are those two definitions? Conceptual definition and operational definition. Very good. Thank you. Should I just continue? Yeah, yeah. Yeah. Okay. I'm not done yet. I have one more small presentation, okay? So I'm going to talk about evidence-based practice, quality improvement, and research utilization. This is a small presentation, okay? We heard enough about evidence-based practice, and we heard enough about quality improvement from Dr. Lee. So I don't have to go into details of quality improvement because she did a good presentation on different types of models that is being used in quality improvement. And so I'll give you a summary, then we will compare what are these difference, between EBP, quality improvement, and research utilization. So when you think about it, there is a very fine line between these three, okay? Not sometimes you might feel like everything looks the same, but there is a fine line because we started with the quality improvement in 80s. Now we see more evidence-based practice. So it is shifting from, but even then we do, all hospitals or wherever you're practicing, they need evidence-based practice, quality improvement, and research utilization. So we cannot say this is important, that is not important. Everything is equally important. So you heard enough about evidence-based practice, and I have the same graphic here. So, so I have a couple of slides with quality improvement. So Avidis Donabedian is known as the father of quality improvement. So quality improvement is defined as data-guided activities intended to bring about quick improvement to a clinical problem in a particular setting. Most of the time it is done in a particular setting when you want to fix something quickly because you don't have time to do extensive literature review before you make a decision. So fundamental concepts of quality improvement, Dr. Lee explained this. Do you remember structure, process, and outcome? Most of the time the quality improvement projects are to improve a process. And she gave good examples too. Patients is taking, I think the emergency room taking too much time. So they had to improve the process. So structure is adequacy of facility, and she talked about structure too. What is the structure when it comes to patient care? The hospital, the surrounding, the staff-patient ratio, right? That whatever is there, that is the environment, that is the structure, the equipment, administrative structure. Then process of care, completeness and appropriateness of care. Are we providing the appropriate care? And coordination of continuity of care and prevention. Outcome is outcome of medical care and restoration of functions for patients. So why quality improvement? To correct workflow process, improve efficiencies, reduce variations in care, and address clinical, administrative, or educational problems. She talked about standardization of the care. I don't know whether you remember that. So quality improvement seeks to standardize processes and structure to reduce variation, achieve predictable result, improve outcomes for patients, improve healthcare system and organizations. How many of you remember PDSA? You all have very short-term memories. We heard about it this morning, PDSA. And she explained it very well. Plan, do, study, act. Okay, PDSA. That is a framework, one of the framework. What are the frameworks she talked about? Something to prevent waste. You remember lean? And she talked about Six Sigma. Okay, now you remember. So this is one of the models that can be used for quality improvement. Plan, do, study, act. What is planning? Develop an improvement plan. Do roll out the plan on a test basis. then study the actual result or measure the impact of what you have done. Then take action. If nothing has done, then repeat the cycle, see what was the deficiencies and repair it. And remember, she talked about root cause analysis. Yes? No? So root cause analysis, what was the issue? Where was, and she gave a good example about medication error. What was the root cause analysis? Like, why did it happen? Instead of blaming the nurse, what are the circumstances that led into the medication error? I don't know whether she discussed it today or the other day. Okay, that's PDSA model. So for quality improvement, you have to have an aim statement instead of a question, okay? You have to have an aim statement and answer those three fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? What change can we make that will result in improvement? So the next one is research utilization. So what were we talking about so far? Quality improvement, right? And now research utilization. Process of applying research findings to healthcare practices and decision making at individual practice level. Research utilization, sometimes we do it just one nurse. I read something, then I know I need to refine something I was doing. Or it's not like, not a major, changing scope or anything. Something that I read scientifically, sound research, then I change my practice based on that, okay? Transferring knowledge to actual practice, it could be on a nurse changing what she is doing, or may involve in changing the protocol at the unit. Or sometimes it can be used for education to spark additional research. So here is the research utilization path, emergence of research findings on a topic. You found out there is some new study and there is new findings on something that you are interested in. Then evaluation and integration of that finding, that is the best research evidence. Then efforts to use findings in practice. That is research utilization. There is another slide that shows what is the difference between evidence-based practice and research utilization. So there are different types of research utilization: indirect, direct, and persuasive. So indirect is involving change in nurses' thinking. That's conceptual utilization. It's changed how I was thinking. Then direct is direct use of findings in patient care. Then persuasive, involve the findings to persuade others to make change. So as a faculty, like I do that a lot. I read new research and then I tell my students, these are the new findings. This is how you do things. So that's like persuasive, encouraging someone to make changes. So here, this is a research utilization path and EBP path. So if you, research utilization path, emergence of research findings on a topic. Whereas EBP path, you start with search, you start searching for the best evidence to make a change, okay? So then the other steps are similar: evaluation, integration of findings, best research evidence, then evaluation of other types of evidence. So what do we do with the evidence in this path? The difference is research utilization path, emergence, you found out there is some new research out there. Whereas EBP, you are looking for evidence to see what is the best evidence out there. So these are some comparison. Evidence-based practice, I'm not going to read it, you already heard it. Quality improvement is improving healthcare services, systems, and processes locally to improve outcomes. The research utilization, using the research findings to make practice changes at the individual level. So goals of EBP, QI, and research utilization: evidence-based practice, find existing research that demonstrate which policy, practice, or procedure is the best. And QI, improve patient outcomes by methodically identifying areas where performance falls short. Research utilization may lead to change in practice based on one study. Evidence-based practice we never do based on one study. Research utilization can be based on one study, okay? But you're not making a major change in your unit. It's like sometimes it's your way of thinking. Sometimes you persuade someone to make a change in the practice. So In relation to literature review, evidence-based practice needs extensive literature review, and the literature review itself is a whole semester process. So for QI, projects typically don't involve extensive literature review, and research utilization also does not require extensive literature review. Which of these, out of these three, which one needs extensive literature review? None? Evidence-based practice needs extensive literature review because you want to figure out what is the best evidence out there, okay? So quality improvement will have a aim statement. Evidence-based practice will have a PICO question. Research utilization does not require a question, but if I add research there, then you need to have a research question. So here is another comparison table. When you think about method, quality improvement, PDSA, you can also read it. Level of evidence is very important. I talked about level 1 and 2, that is what is required for evidence-based practice. Research utilization, no extents, you don't have to look at the level. Then sample, QI is usually focused on unit level, and EBP is usually evidence-based for focusing on patient populations bigger, okay? Then research utilization, we don't look at the sample. Sometimes, it's making a change in how nurses thinking. Human subject, IRB, are you familiar with the Institution Review Board or human subjects? I don't know what is the terminology you use here. So anytime where there is a patient is involved, then you have to have IRB approval to conduct the outcome assessment. But research utilization, you don't have to have IRB. So implications, QI is process change. Remember when I talked about quality improvement project, it's always to improve a process. Then EBP, it's a practice change, and research utilization is understanding the change. So dissemination, QI, unit or agency, but in the morning you heard Dr. Lee said quality improvement projects can be published now. So I wanted to add this research, one slide on research. What is the difference between research and evidence-based practice? So I want you to remember one thing. Research, we are producing new knowledge. Evidence-based practice, we are translating that knowledge to the bedside. Did you all understand? So PhD versus DNP. PhD produces the new knowledge, and the DNP translate that knowledge to the bedside. Can you remember that? Like a couple of sentences, okay? The difference between research and EBP, and the difference, one difference between DNP and PhD, okay? And we heard in the morning, PhD is a practice doctorate. PhD is a research doctorate, and DNP is a practice doctorate. Okay, we already talked about that. Any questions? Oh, okay, the last slide. The method, so quality improvement, evidence-based practice, and research utilization. This is like a three-legged stool. So if one leg is not working, you cannot sit on it, right? So for a unit, we need all these three. Because you don't want to have a one leg or two legs stool. You need to have a three-leg stool, so it can support your practice well. Thank you. Do you have any questions for me?
Thank you, ma'am, for those wonderful sessions.
Thank you.
Now we request Dr. Beena Joseph to lead a session on Scholarly Evidence-Based Practice Project, Problems Identification, and Methods to Address the Problem, Plan for Implementation and Evaluation of the Outcomes, and also to provide the Evidence-Based Practice Project report.
Okay, I am back. How many of you are feeling sleepy? Okay, but I am feeling sleepy, so it's your responsibility to keep me awake, right? Okay. And I cannot ask anybody to pinch me, there is nobody besides. If I was sitting there, I could ask that, but yeah, so you cannot sleep. That's the ultimate disclaimer is you cannot sleep, then I will be just sleeping here. Okay, so since we already heard about all the EBP steps and everything, right now it's time for you to write down that why, right? It's just those who are actually say, yes, I'm going to go with this DNB program, this is the time you're going to start, right? So just go ahead and write everybody has a pen and paper? Go ahead and write your why question or that burning question. Okay, is this right? Is there something I can do to change this practice? Or I feel like there is something else I can do to improve. So if there is anything pressing like that, go ahead and write it down right now, like maybe 30 seconds. And then we can come back to that at the end. So you're going to tell me like, okay, so this is what I'm going to do with it. And I can say this will be your start, right? And as everybody else was mentioning here in the morning also right now, this is going to be like a journey. It's not going to happen just over 1 week or 1 month. So you need to start from now. Did everybody write something? You all have some ideas? Okay, so what I'm going to do is I'm just going to, like you learned about the EBP steps. There are more to it, like when you actually submit a proposal and then when you go forward with that project, implementing, evaluating, and everything. So there are a couple of other steps, like in that process, you need to incorporate, which again, you need to start from the very beginning. Okay, so when we talk about the scholarly EBP project, again, it's the generation, synthesis, translation, application of, and dissemination of knowledge. Aim to improve health and transform healthcare, and it's related to a practice issue, so that's what you wanted to just ask like that why question right now. And when you ask that why question, just go ahead and think about it. How can that knowledge be applied to those problems? How can it be helpful to an individual, a group of patients, or to an institution? Because even though it says a practice problem, patient-focused, it's still going to impact not just the patient, it's going to impact the institution or the organization where you're working, right? When the patients are safe, then our outcomes are good, and then the metrics are good, our revenue is good, and then we get, when somebody is sick, where do they want it to go? Wherever they get where do you want to go if you get sick? Wherever we get the best patient care, right? So that's where we want to. That's where we want to take our loved ones. So when we say that it's a practice problem and you practice evidence-based practice, that is going to impact patient, family, community, organization, everywhere. So, and the DNP project, it's a demonstration of how practicing scholarly nurses can build new knowledge. When we say that, yes, we are translating the scientific evidence, we are translating that research findings into the practice. As we implement that findings on your journey, you may also find, okay, there should be additional research. So that's something which you have like a recommendation at the end of your project. We need a little bit more clarity on this. Or maybe I found, like doing the lit review, I found new evidence there, so maybe somebody needs to do research on this. So you can also build new knowledge, and also you're building new knowledge by implementing that evidence-based practice and say, okay, if you do this, the outcome is going to be better. Or don't think that all the project is going to give you the positive outcome what you're thinking. There could be, maybe that's not working. And then again, that's where you stop. You're going to say, okay, let me do further lit review and see what other evidences are there. Maybe intervention A is not working with the patient population I'm handling. Maybe the choice of B can work, right? So again, it's not stopping there. You are going to continue that path. So the EBP, best research evidence, clinical expertise, patient values, we are putting it all together. You already heard about it. This is something, we're just going to carry over. And like when you do the project, this is where we are basing it. So that's why it's coming back and back again. Okay, so as I said, you already learned about the phases, like spirit of inquiry and lit review and appraisal and all those things. But again, when you think about the project, there are other factors to consider. Where am I going to do the project? That is important, the project site. It may be like the same project site for all of you, maybe different units. So what's my project site? What's my patient population? You need to start with a needs assessment. Some topic may be of interesting to you, but is that a need for that particular unit or particular organization? That is also important. The reason why that is important is that's the only way we can succeed with that project, right? If there is something which, wherever you're doing it, that's not of no benefits or that's not a need there, then probably that project outcome is not going to be what you're expecting. And what is the significance of those problems you identified? What are the background, and then who all are the stakeholders? It's very important because for us to continue, implement and evaluate that project, we need to get buy-in from our stakeholders. So you need to identify who are the stakeholders. From the very beginning, you need to approach the right people. You need to ask, you go through every steps of your journey. You need to actually update them, meet with them, right? So that's another important piece you need to consider. IRB process, which is the human subjects protection. So like, I don't know how it goes to be the process here, but it could be like, the university IRB process, or it may be like the hospital. Sometimes you have to get the university as well as the hospital or the organization you are doing. And that is also, depends upon what's the process here. It may take 1 month, 2 months. I don't know what's the review process here. Anybody knows? Any faculty here, they can probably contribute. There are times the IRB, the review group meets only like once a month or twice a month. So when you are thinking about your project, you need to make sure that you are starting this process early. And that's why you see those courses, when you look at the curriculum outline, there are some courses starting from the very beginning to prepare you to actually submit that IRB. The other things are theoretical framework and change theory. I'm going to explain it as we move along. Implementation, evaluation, and sustainability. It's not you identified the problem, you identified the intervention. Now, as a DNP student, you have to implement, evaluate, and then come up with the outcome. Then what are the sustainability plans, right? How are you going to sustain that project? How are you going to continue? How are you going to disseminate? All those things you need to consider. So you wrote the problem, and then again, it's like a concept map, nursing process. Just write down all those pieces, and at the end, start actually connecting those pieces together. Okay, so when you select the project site and population of interest, when identifying the phenomenon of interest, consider the phenomena that are contributing to the current outcome of the whatever the organization is experiencing now. And then ask, what is interesting to me? Why the topic is interesting, right? And then also, when identifying the problem, why the topic is important, what is it about the topic that is a concern? Maybe some topics are interesting to me, like, okay, I wanted to do something with the diabetic patient, but if you don't have the right patient population where you are planning to do the project, and then also, if that is not a concern of that particular unit or the organization, then is that a real topic you wanted to take on to do the project? Maybe not. You may want to reconsider that. And then also the other question you wanted to ask is there a need to change nursing practice to improve patient outcomes? You probably identified something, but then again you need to understand, there is a need, then you can go forward with it. So that is why identifying the problem, project site, who all are your mentors, stakeholders, all those things are important as you move forward with your project. The other thing I will say, to avoid frustration, keep your options open. You probably will write one topic and then think, oh, I can do this, I see this, and then maybe it probably will turn around, you may not be able to do that project for different reasons, right? So it just, you cannot just go with one idea. And I will say, like, even you started writing, maybe probably have like 2 or 3 concerns, maybe that's better, because of that way you can see. And it may be also connected each other, right? And then the other thing is sometimes we get so excited and we wanted to fix everything. Very careful with that also, especially when you're in the student period to complete and have that degree. Make sure you narrow it down because of the time factor also. See how much time you have to implement and evaluate and all those things. So narrow it down. Even if, let's say, I'm just giving an example of diabetes. There are several things you can do with, right? When you come to the diabetes, what is my focus? Narrow it down and then just kind of take on those something which you can accomplish during that time frame. But you're not stopping there, and that topic you wanted to continue once you graduate, you need to continue from that, right? You build on what you did, and then you can continue and then take on from there. So again, keep your options open, otherwise you will be getting frustrated. Okay, I did all these things, I did all this lit review, and then now you're telling me I cannot do it. It could be for different reasons. So just make sure, very careful with when you finalize the topics, and consider, as I said, your project side, talk to your mentors, talk to your stakeholders, all those things needs to happen upfront. Okay, when you consider the project side again to identify, is this a real need at the project site? Do a SWOT analysis. And then again, I will say, I can't stress that enough, talk to your stakeholders. You need to get their buy-in, right? Those leadership support is very important for us to succeed. And needs assessment, identification of the gaps, so do a gap analysis, and I have a template after, so you can actually look at that, how to, you can take that and then see, like, you just do the gap analysis to identify what's the actual problem, what can I do, what's the current state, and what's the desired state. And then mentors, finding that right mentors, the expertise in the area of teaching, experience in the area of role and population practice, it's very important. And make sure they have that high level of experience and practice concurrent with the focus of your program. Theoretical framework, it is important. You can use 1 theory, 2 theories. It depends upon your problem as well as how do you want to implement, right? And then you could have like a theory for selection of your intervention. You probably need to have a theory to guide your implementation process, because there need to be a structure, otherwise it's not going to happen. So select a good theory to actually do that implementation, and I have an example I can explain to you later. When you select the theory, just ask some questions. Reflect your personal nursing practice, and also this theory is going to help to describe, explain, and predict the phenomenon in which you are interested. Then also ask the question, like, can this theory be used as a guide or a framework? Does the theory offer a way to develop, assess, implement, and evaluate? It's very important, right? So that's why I said, like, sometimes you need to also ask, look for some change theories, because what you're looking is to change some practice. So some change theories is going to help you to actually guide that process. And then the other question is, will the use of this theory help to support excellent nursing practice? Again, the theories are not just limited to the nursing. You can actually select the theories outside of the nursing, because some of the implementation theories outside of nursing, right? So you may want it to just look outside of the nursing theories. When you select some tools and instruments, again, the validity, consider the validity and reliability and the permission to use. Because some of those instruments out there, you can get it for free when you are a student. Some of the instruments you can get it from the publisher. You can write to the publisher. You say that I'm a student, this is my student period, this is my expected graduation, can I use this instrument? They'll give you permission, written permission, like electronic permission, right? And then that probably you need to submit that with your IRB process. So some other permission you could actually contact the author. You can get that also. And also consider the cost. In my experience, a lot of times students can get free for like a year or some, and then you just have to follow their guideline. So again, the IRB, so like how do we submit the project protocol? You need to submit a project protocol. I won't say there is a unique template for it because it depends upon where you're submitting your proposal, right? So follow the project protocol template from your institution or the IRB, and then you just put all the information and then submit. But before you prepare the project protocol, you are going to do the project proposal. The proposal has pretty much everything what you need to take it and put it in the protocol. The protocol is a mini version of the proposal. So the proposal is going to be bigger than the protocol. So if you have everything in the proposal in order, it's easy for you to transfer that information. And as I mentioned earlier, the IRB approval, you probably need to get it from the university, project site, affiliated institutions, and that definitely your faculty will let you know the process. So the implementation, evaluation, and sustainability. So the project team, the DNB project allow you to practice and refine skills to lead a collaborative team. So again, when you think about the project, you also wanted to consider who all are going to be the key members of my team. Because sometimes when you do some projects at the unit, you probably need to help, need help from the other staff nurses, because part of it may be something you want them to collect some data, or maybe they're part of your education, they're part of your review. So just make sure who are the team who will be involved when you're doing the project. And also, it's very important, the organizational commitment. That's very important. That's why I said just meet with your stakeholders from very beginning. That is going to make your process smooth. The other things to think about is the data management, data collection, data storage, data analysis, and then also make sure you know how long the data needs to be kept based on your institution and the IRB protocol, IRB approval. Okay, so just give an overview. I have a project so that we can take the step by step. So it just gives you a little bit more idea about what we will be doing during the project, how extensive it's going to be. So I thought like giving you an example step by step probably will be better. So this is a project. This was the heading. Again, when you submit final, like make sure that heading needs to be very clear and not too fancy, but it has to be clear to the topic. So this is a project, motivational interviewing and pain management, improving patient satisfaction. It is actually the project I did it when I was doing my DNB. So some of the references you will see is a little old because this project was completed in 2016, almost getting 10 years. So you may see like some of the references are 2010, 2015. So being said that, always just make sure you will start your search within that 5-year time frame, and not necessarily that's the only thing you're going to do it. Once you do that 5-year search, I may extend to maybe a little bit beyond. Sometimes you also have to go back way old because you may wanted to use some original research. So in my project, I used one original research. That's an instrument I used. So again, there is nothing wrong with it, but always just make sure you're using the current evidence. Okay, so the problem, why did I come up with this problem is when I started thinking about pain was always to my heart. The reason is like when I was actually at the bedside so many times, sometimes patients comes with a chronic pain. You hear these comments, I don't know if some of you might have heard it or maybe not. Well, that's a frequent flyer, always come to the ER. Oh my God, whatever we do, the pain, that's have zero pain tolerance. So a lot of comments like that. And also, it was very, when I thought about the pain, definitely always in my mind, what can I do to make an individualized approach to the pain management? So I can give you an example also, like, I don't know, if anybody here with a migraine headache, you can relate to it. So this particular person has a migraine headache, and the physician already know that for years, this person is suffering from migraine headache. On the other end, started complaining about headache, and then this particular person really said, my headache right now is not related to my migraine. But the answer was like, oh, you have a migraine, sometimes the pain comes like that. And then also, going to the doctor's office, the blood pressure, when they look at the blood pressure, 120s over 80s, and then they'll say like, okay, that's not my blood pressure because the baseline, we all learned, okay, for male, it's 120/80, for female, it's 110/70. That is, I mean, that's like a baseline it's giving for us to get an idea, but a person who has a 90/50 baseline for many years, if that person's blood pressure is 120/80, do you think that's a concern? Yes, right? So that's another thing. You have to always just know what's the baseline. So that was also going on, like maybe for like a year. Okay, that's fine. Are you stressed out? Or maybe it's a little stress. But eventually, this patient was giving already like, I'm getting sick or something is going on for like a year. And it took a while. It took like that person to collapse one day for them to really deep dive into what is going on with the patient. So again, if somebody was listening to that patient, okay, this headache is not my migraine headache, my blood pressure is not right, probably I don't think that person could have collapsed, okay? And then getting into the emergency court team and getting into cath lab, which all those things should have been avoided if somebody was listening and ready to provide that individualized care. So that incident, like, you know, the pain was always close to my heart. But again, I didn't know if that is something which I can do it. So I went to my project site and then also did some literature review why this pain is a concern. So like in US, it's really if the patient satisfaction, the pain management, all those things contributing to our payment. So I'm not going to read all these things, but there are literature out there. It says a lot of 25% of the patient, you know, the US population is affected by chronic or persistent pain. And then estimated cost of pain-related healthcare, loss of income, work absence, it's like almost 100 billion. And then one of the CMS study in 2015 had, like, it says 23% of the skilled nursing unit patients are returning to the hospital within 30 days of discharge. So that's the background about the pain. So if the patient comes back to the hospital within 30 days of discharge, the payment is affected. There, we don't just get payment for, like, if the patient is admitted and the patient was in the hospital for 5 days, so here you go, like, you know, 50,000. No, there is nothing like that. It's based on the performance. It's based on the patient outcomes and then patient satisfaction. There are a lot of factors contributing to it. So that's a little bit of background and significance. And then, so with that, like in my project side, I was talking to a different department, and then the customer, the patient relations officer, one day I met with her, then I was just discussing about this because I know the pain is one of the factors in the patient satisfaction survey. So that is a survey our patients get when they get discharged, and then it's based on their experience in the hospital. It's called the HCAP survey. So coming to find out, patient dissatisfaction with the pain management was a problem in our acute medical surgical units. And then, so the hospital, the project site I had was a comprehensive hospital in Southeast Texas. And that was one out of the 12 acute care facilities they have, and it's a non-profit hospital. Now they have like a 13 acute care hospitals and almost 25 plus outpatient clinics and almost same amount of surgical centers. So they have a lot of facilities within that organization. And this particular facility within that organization has like 426 licensed bed and 6 40-bedded acute medical surgical units. Means that's like a 240 out of that 426 is medical surgical patients. So it was a concern for that pain management in that particular unit. So I did the SWOT analysis, and this is the template. You can use it. It's like you're looking for the strength, strength, weaknesses, opportunities, and threat. So when I look at this project site, I know you cannot see that, but some of the strengths we identified was, this is a magnet facility. So when we say magnet facility, they are striving for the excellence. They need to keep up with the patient satisfaction, evidence-based practice. So I knew it, okay, they will be in favor of it, right? And then they have a research council, they have a patient relations department, solely looking for all this patient satisfaction. And this particular unit also had availability of admission discharge nurse, where I knew it, if I select this project, I can get some help from those admission discharge nurse. And the weaknesses were inconsistency in using pain assessment and inconsistency in following up with the pain management, pain status. And one of the reasons at that time I was doing, there was a staff shortage because the facility was using a lot of agency staff. There was like, agency staff is like, they come, they have like a contract for 3 months and then they will go, right? So there is not like, the commitment level is not that high as the full-time employees there. So the unit had a lot of agency staff. And then also, the intervention I selected, I wanted to do was the motivational interview because it's a patient-centered approach. And definitely, the staff unfamiliarity is going to be a weakness, which I knew it already. And then opportunities was like recognition of the project outcome at the micro, meso, and macro system level, because I knew it, if this is this outcome, you can actually take it, start with the unit, you can go to the hospital-wide, and it can go to their organization. And then using the motivational interview is a patient-driven, patient-centered approach, and the availability of HCAP survey result, because you get that every month, right? You can run the report pretty much every week and see that progress there. So that was another opportunity. And then, of course, when the satisfaction is high, there are employee unit incentives in that particular facility as well. So those are the opportunities there. And the threats, the number of new admissions during the period of project implementation, I didn't know how many new admissions because I have to do with the new admission, new patients. And then the number of HCAP survey will be returned during my time frame because I have to complete the project and graduate, right? So that was some of the threats I already perceived before I start the project. The lit review, I'm not going to read it. Those are the engines I searched. And then out of that, the level of evidence used. For the interventions, it was all level 1 evidence, but then I had some to support my other background and all those things. I had level 1 to level 4, but mainly it was level 1 and level 2. So the PICO question was, among acute medical surgical patients, that was my patient population, how does the use of motivational interviews, that's the intervention at the time of admission, influence patient satisfaction associated with management of pain, my outcome during hospitalization. That was my time. Sometimes the time may be 3 to 4 months, like that. But this one, because my outcome, I was going to evaluate the survey, the HCAP survey, it's based on the patient within that time frame before they get discharged during the hospitalization. So that was the PICO question. The project timeline. So this is another thing you wanted to plan. When you start the project, just make sure you have a project timeline. Look at where you start from based on your curriculum, where you start, and then also how long you have it, right? And then write it down. This one, I had to finish this over a year. That was my time frame. And then between 4 different courses, so I started. But all my selection of project site and everything else started before what I put it in this project line. So just have a clear picture. It's not going to be exactly the same, but at least it gives you some kind of structure to start and finish that project. And now you have to select the methods, design how you're going to recruit your samples, what's the sample size you need, what are the exclusion, inclusion criteria. So all those things you need to plan ahead. And again, for that, you also need to know your project site, how many patients, and what's the time frame, how many admissions per day, and what type of patients are getting admitted. So based on that, you can actually select your sample. So mine was 83 acute medical surgical patients, and I approached 122 patients. I believe 101 said yes, they will participate. But out of 101, I was only able to complete 83 because there were several steps. Initial was submitting, I had to get the consent form signed, put it in the medical records, and then start the interview. So starting with an instrument called the PBPI, that's the Pain Beliefs and Perception Inventory. That will give you an idea about patient's perception about the pain because you want it to individualize, right? and that instrument needs to be, the way I wrote my proposal was I'll complete that within 4 hours of their admission. So that is why I only got 83 out of 101 said yes, because some of the patients within that 4 hours, when I went back to the room to do it, they probably were in radiology department or somebody else was in the room, and by the time I went back, the 4 hours is over. So based on my proposal, I cannot use them. So that's why I ended up with the 83 patients. And the age group was 18 to 70 years, convenient sampling method, because definitely I wanted to get as much as patients as possible during the time frame. And the exclusions were not able to self-report pain or complete the pain beliefs and perception inventory, or the pain CQN survey, pain care quality nursing survey. That is a survey I used for the immediate outcome before they get discharged. So if they were not able to self-report, or like to complete that survey, then those patients were excluded. But if I had enough time, probably, or maybe wanted to continue, I can consider the other patients because we have language lines and I can use them. But then again, I have to change my project because they are not really self-reporting even though you use the language line. And then patients with the psychiatric disorders or cognitive impairment was also excluded. And then that's actually the chart you have it there is basically my patient population and their diagnosis. That was from my outcome evaluation. Okay, so the intervention was motivational interviewing, and again, that's a technique, and it's a patient-centered approach. It's a communication style, and you use open-ended questions to start with to learn more about their pain beliefs. What do they want us to do? What are their thoughts about? Because some patients don't want to take pain medications. They wanted to try other alternatives. For one patient, pain level of 3, maybe for other patient, it's pain level of 5. Some patients don't want to do any interventions unless it's more than 5. So just wanted to get a little bit about their perceptions, and also the PRN medications. There are some patients, okay, can you bring the medications as soon as I can take it, because I don't want my pain to go too higher, right? The PRN medications, you're not going to give it unless they ask for, but there were some patients who really asked for that, and what I did was I communicated that with the unit nurse, and then at that mark where they can take the pain medicine, they're not going to bring it unless they have the pain, but they were making sure they're doing a follow-up pain assessment, and based on that, they were doing the interventions. So starting with the open-ended questions, then affirmations, like you are kind of, okay, this is what you want to do, this is what I heard, so that's also come to the reflections. And so it's like reinforcing what you heard and what they wanted to do, and then summarize it. So what I heard is your pain, this is what you think about the pain, these are the interventions you want to do with you don't want to take any pain medicine till the pain goes this much. So whatever they said their beliefs about pain, we are summarizing it. Again, it's very important for us to understand the patient-centered approach, the patient's preference for the pain and pain management, because again, for us, we get patients from different culture and like different nationality. And you will be surprised, the way they look at the pain or the pain management, it's different. So we need to know, we cannot go with our thought process about the pain management to the patient. Same way, even if here, I can see you may have patients from different states. They may have a different perceptions about some of this healthcare and then the interventions and things like that. So again, patient-centered approach. So that was my intervention. And the theoretical framework, I used 2. One, for the selection of the intervention, G. Watson's theory of human caring, and that actually lay with the intervention I selected. Okay, it actually focused on that communication, active listening, patient-centered approach, consider the patient as a whole. So all those things fit in with that G. Watson's theory. So that's why I selected that to actually guide my intervention. And then Roger's diffusion of innovation theory was the theory used for the implementation. That is a change theory. The good thing about that is it has several steps as you wanted to plan your implementation. Couple of things are the relative advantage. Okay, I think I have on this slide about it. Let's see. Okay, we'll talk about the theory in a little bit. Just to give you an idea about the tools I use, the PBPI instrument, that is the Pain Beliefs and Perception Assessment tool, and I got permission to use that from the publisher for 1 year for free. And the pain sequence survey, that's a 14-item Likert scale, which I use before the patient discharged from the hospital. And I got the permission from the author, and that was like an email communication actually to the author, and then they responded right back. It didn't take like more than a week before I got the permission. And then also developed a sampled motivational interview communication template to make sure the intervention I'm doing is consistent. And then also once we finish, for the unit to continue, they need to have like a template. So those are the 3 instruments I used. The IRB approval, like for me, I had to get it from 3 different places. One was my university from the project site, under the project site, the hospital and the affiliated health science center, because the hospital I did, they were associated with a teaching institution, so I had to get the hospital as well as that particular teaching institution's approval process. And then before submitting that, I had to get a project site approval, letters from the stakeholders, and then also develop the informed consent, and that is the consent I used to get to recruit my patients. Okay, so the change theory, as I said, the Roget's diffusion of innovation theory, it's actually, I really like it, but again, there are so many change theories out there, so just decide which one you wanted to use. So in this theory, it's broken down like the steps of the implementation. The first one is the knowledge stage. So the stakeholders, the unit, they need to know the existing problem, and then they also need to know the intervention because they're not going to be familiar with it. So whatever you have to do to make them familiar with it, if they are continuing, then you need to teach them about it. So that happens in the knowledge phase. The persuasion stage is we need to make sure there is a favorable attitude towards the project. So it's like a leadership buy-in. Then you need to submit the project proposal. You need to review that with your stakeholders. So those are the persuasion stage. And then decision stage, your project plan, responsibility of the members, and then yes, I'm going to start the project this time, so all those details, right? And in the persuasion stage, to get buy-in from your leaders, just make sure you need to be able to explain what's the relative advantage, what's the compatibility, complexity, trialability, and observability. So which means they need to know, okay, why is it important? What is it going to help? How is it going to help, right? And then is it too complicated to implement this? So when I consider the facility is also a magnet facility, they are looking for how to improve their patient satisfaction score. And then we can do it because pain assessment is part of our vital signs, so everybody has to do pain assessment, so it's just a different approach. Everybody has to make sure that the pain is managed properly. And trialability, yes, I can do it with that patient population, and we can also transfer to the other units. And the outcome is really observable because you can do the survey regardless if I use a different survey or not, they would be able to see it from the HCAP survey. So that's like a given survey for the hospital, right? So they are going to see that. And then the implementation stage, so you notify the leadership, participant consent, and then do the intervention, pain sequence survey. All those things happen in the implementation stage, and the confirmation is report of the project finding internally. Then it's a sustainability plan and ongoing support. When it comes to the ongoing support, I had several sessions offered after the project was completed about the motivational interviewing for the project site staff members. Just to give an overall, this is the overall pain sequence survey analysis. I'm not going to go in detail. The only thing is you need to have a plan for your outcome evaluation. So just think about what statistics, what type of statistics you are going to use it, descriptive, maybe a t-test, ANOVA, so whatever that is. That is why there is a course also, they're talking about that also in your curriculum, right? And that's why it's important because you have to get that outcome, you have to analyze it. The results, some of it, most part of it, it was favorable, I got it, but there was a section in the pain sequence survey, it has like 3 components, being treated right and comprehensive nursing care, and then some of it is related to the medication administration. So being treated right under the comprehensive nursing care, the outcome was what I was looking for. But the medication part actually didn't have like the positive outcome because again, Why it was, because that's purely on the medication. My focus was not part of, on the medication. And then the challenges with the medication, what the findings based on their open comments were like, okay, sometimes it was getting the medications prescribed on time from the provider. The other incidental finding we had when doing this project was the patients who were transferred from ER and PICU. They said, I asked for pain medicine, I was really in pain, but they said when I get transferred to the unit, they'll give the pain. So what happens is when you transfer, the electronic health record needs to transfer from this unit, they need to go and change it from this, wherever they're coming to the other unit, unless then you won't be able to access their orders or give medications because you're scanning and all those things. So there may be a delay if the patient's pain was not managed before they were transferring. So when doing that, finding that, and then reporting that out, when I did actually the presentation with the unit leadership and at the project site, what they did was they took that finding and created a process, like a quality improvement. So they started a process of retrospectively going back and looking at the data about the patient's transfer time and the patient's level of pain when they reached the unit. And there was like quite a bit data to find that, okay, there were like patients were really reporting high level of pain when they got transferred to the unit, and there was a time frame sometimes, like for 1 hour, the patient did not get any medication, so whatever they were asking for, because of different reasons. So what they started was like monitoring that, and then they made it a process where before you transfer a patient to another unit, they need to document the pain level 15 minutes before the transfer. So if the pain level is more than 3, they need to also document what interventions they did it. So that was like a project, it continued, and that was the sustainability there. So they took it from there and they continued that project. Dissemination, again, you need to think about where you're going to disseminate the findings because you found it, and once you have that positive outcome, you wanted to see that someone else is taking from there and using it so they can also have the same impact, right? So I did at the project site, unit staff meeting, leadership rounds, magnet committee meeting, and at the EBP council. Then in the project organization during the annual research day, and at the local university, and at the international level, this was presented at the Sigma Theta Tau International Leadership Connection in 2017. So again, when you develop your project, you need to actually think about it, where can I disseminate this? Okay, so that was a little overview of the DNP project, an example. I know it was probably a lot of information, but did you get an idea where to start? What are the components? How you come up? How you start? How you come up with the final product? Yes? No? Any questions with that before we move on? I mean, the next one should not be that long. Okay, if you don't have a question, I have a question. Did you get an idea where to start and then what components probably needed? Or at least a starting point. Did you get an idea about a starting point? Those who are actually going, okay, who all are said that you are deciding or you have decided to probably start the DNP or thinking in next 2 years? Did you get an idea? I need an answer, yes or no. It's a very, it's a closed-ended question. It's very easy to say. Okay, who all are sleeping here? I thought I was sleeping. Okay, did you get an idea where to start? Come on, I need to answer. I need an answer before I move on to the next one. Yes, no? Okay, so what's your why question? Anybody wants to share your why question or your burning question? No? Okay. Okay, so next one is just a little bit EBP proposal and EBP report writing, what components to include. Pretty much you saw what it actually takes. So just putting it all together, the first one is the gap analysis. Remember we said, do a gap analysis as you move forward with the project, like when you have the topic. So what is the current state, what's the desired state, identified gap, and the gap due to, is it due to knowledge, skill, or practice? And then methods used to identify those professional practice gap. Is it direct observation? Is it from retrospective chart review? Is it something like an outcome evaluation of some of the satisfaction survey? Or is it your quality indicators? So just identify those. So that this is very important so that it can guide you where you want it to reach. SWOT analysis, internal factors are the strengths and weaknesses, the external opportunities and threat. So that's a template you can use it to do your organizational analysis to support your project. Pick a question, just a sample, like for if it's an intervention type, you can actually write. Maybe you want to take 30 seconds, 1 minute and write your question right now. Why don't we do that? You already wrote a problem, right? Don't worry, I'm not going to ask you, you can write it. And you can keep it with you. So in like the patient population, what population you want to focus, how does, that's the intervention you are thinking about, compared to, if there is a comparison group, sometimes there is no comparison group. Like for me, there was no comparison patient population per se because I didn't use the same patient population, right? But I did compare the patient satisfaction before intervention and after intervention. So the HCAP survey, that's something that was my one comparison for the survey, the outcome result, but no patient population because I didn't use the same population before and after intervention. It was a different group of patient population. And then also it comes to affect the outcome. You write the outcome there, what you are thinking about, and within whatever the time frame you are thinking about, right? So basically, most time it will be probably intervention or like a therapy for your project. Okay. The project protocol, as I mentioned, it is customized based on your organization, based on the IRB site, like the IRB, whichever the hospital or the university IRB process, they should be able to tell you the project protocol, and I will say like it's a mini version of your proposal. Okay, this is a sample, probably like the headings for your project proposal, the project description, just like an introduction, and then the background and significance. Under that, your practice problem, your significance, incidence, privilege. If there is any quality, safety, legal, and ethical implications, that's what is going to go under the background and significance. Then you come up with your P-code question. In that, you have to define your patient population, your intervention, your comparison, outcome, your timeline, all those things you need to explain under that. Then your operational definitions is important. You need to give a brief overview of the theoretical framework you selected and why you selected that, how that theory is going to help your project. And then definitely, once you have the lit review, the synthesis of the literature, that is important. Practice recommendation. So once you have the lit review and the synthesis, then you say like based on this lit review, this is the practice recommendation that's supported, right? Based on the current evidence. Then the project setting, you need to actually explain. So some of the proposal may not have all the organizational mission, vision, and everything, but some may ask for that. Then description of your client, your organizational need, your SWOT analysis, stakeholders, project mission, risk and unintended consequences. Those things comes under that. And then you need to explain your project plan, what change model you're going to use, what are the barriers and facilitators, the timeline, feasibility of doing that project, and then the protection of human rights and privacy, and resources and budget. Those things comes under the project plan. Then the project evaluation should include your data collection, data protection, and data analysis, and then your dissemination plan, and the conclusion, and all the references and appendices, tables, and all those things. So this is going to be the project proposal. Once you have this proposal, it's very easy for you to take the information and put it in your project template. And then once you have your final, once you implement an evaluation, what you're going to add to this, what you did with implementation, what was your outcome, what's your conclusion, what was your limitation, those are the things you will add with the final report. So the proposal, once that proposal is done in the right way, then I will say half of the work is done, right? And a paper, again, it's pretty much the same thing, but you will add an abstract, and then you will also add the discussion of your result, right? Your result tables, and all those things. The summary needs to be part of that project paper. A few things about writing, scholarly writing. Just the building a scholar in writing, the BSW model will actually tell you where do you start and how you connect all those thought process. I thought it would be really interesting, so just make sure, read about it. BSW model for scholarly writing. So what it says is the first one, it says you just have the bonds, right? Independent ideas. So that's what I was asking you, write your ideas, right? And then you may have 3 or 4 ideas, and then from that, you probably still have like some branches out. So those are your bonds, and then you wanted to connect that idea. So like for me, pain and the motivational interviews, how can it help? And then I have patient satisfaction. So how can I connect all those 3 pieces together? So that's connecting those bonds. And then construct skeleton, ideas connected throughout. So like your background significance and the organizational need and all those things, you take it there. Then add muscles to your skeleton. That's where you are going to have that literature support, right? Because you come up with the idea, you find a problem, now you need to have a literature to support. This is what the problem, this is the intervention, and this is how I came up with it. So that's like adding muscles to the skeleton, and then add essential organs, originality and creativity. So how you're going to connect, how you're going to implement your theoretical framework, all those things. Think about there, and then also add the brain, critical thinking and critical appraisal. So it's like once you have those pieces, and then you're putting it all together. Okay, so those things happens before your proposal or before you write a scholarly paper. And a few other thoughts about scholarly writing: write a clear, concise statement. Don't drag your ideas. Just to the point, and then that's it. Begin the paragraph with a simple and direct topical statement. Keep sentences simple and relatively short. Use an active voice, third-person pronouns. Avoid informal terms, slangs, controversial or biased words. Avoid repetition and meaningless statements. Sometimes when you read the paper, you read that sentence, long sentence, and if the same thing is written in a same little bit different structure. Don't do that. Just what you want to say, just say it. That's it, right? Don't add too much narratives, just be straight to the point. So those are some of the things you wanted to consider when you write. And also I will say, after you write a sentence, read it a couple of times to see, like, if I am reading this from a third person perspective, am I able to understand that? So whoever is reading needs to immediately grasp what you're trying to convey, right? So that is how you have to write it. So for that, keep the sentences short, simple, straight, direct to the point. Some resources you can actually get it from, like, about writing from Purdue University. That's also, you can just search online. I think that's it pretty much. Okay. I think it's done, but probably done. Okay, that's fine.
Thank you, ma'am, for that insightful session.
Okay, before I leave, any questions you have? Can we answer anything before we leave?
So, nurse practitioner and those who are aspiring for DNP program can discuss madam for DNP projects. So we have time for 15-20 minutes before this valedictory program. So all, even the NPCC students, so you can also discuss about EBP project.
Everyone, I request all the dignitaries to sit on the dais. Today is a day of immense pride and celebration as we mark the official beginning of a program that will not only advance the careers of our nursing professionals but also elevate the standards of healthcare across our communities. This valedictory session is a time for us to reflect on the significance of this milestone and to recognize the incredible journey that has brought us here.
As a token of love and gratitude, we would love to request Dr. Mrs. Vaishali Rasi Moite ma'am, Dean, Krishna Institute of Nursing Sciences, Karad, to welcome Dr. Mrs. Neela Mishra ma'am, Vice Chancellor, Krishna Vishwa Vidyapeeth, deemed to be University, Karad. Thank you, ma'am. Now, I would love to invite Honorable Dr. T. Dilip Kumar, President, Indian Nursing Council, New Delhi. We would love to invite Honorable Dr. T. Dilip Kumar, President, Indian Nursing Council, New Delhi. Now I request Dr. Neela Mishra ma'am, Vice Chancellor, Krishna Vishwa Vidyapeeth, deemed to be University, Karad, to felicitate Dr. T. Dilip Kumar, President, Indian Nursing Council, New Delhi. Now, I request Dr. Mrs. Namrata Moite ma'am, Associate Professor, Krishna Institute of Nursing Sciences, Karad, to felicitate Dr. M.V. Godpade sir, Registrar, Krishna Vishwa Vidyapeeth, deemed to be University, Karad. Now I request Dr. Neela Mishra ma'am to felicitate the guest of the day, Dr. Punita. Dr. Punita, Consultant, Indian Nursing Council, New Delhi. Next to Mrs. K. Next to Ms. K.S. Bharati, Senior Consultant, Indian Nursing Council, New Delhi. Next, to Dr. Pramila Lee, Professor, Christian Medical College, Vellore. Next, to Dr. Beena Joseph, Professor, Houston University, College of Nursing, Texas. Next, to Dr. Shaini Varghese, Professor, Houston University, College of Nursing, Texas. Next, to Dr. Asha Sharma, former Vice President, Indian Nursing Council, New Delhi. Thank you, ma'am. Now I request Dr. Mrs. Jyoti Salunge, Dean Academics, Krishna Institute of Nursing Sciences, to welcome Dr. Mrs. Vaishali Rasing Moite, ma'am, Dean, Krishna Institute of Nursing Sciences, Karad.
Thank you, ma'am.
Now I request Mrs. Afsana Mulani, Professor, Krishna Institute of Nursing Sciences, Karad, to welcome Rohini Babar, ma'am, Chief Nursing Officer, Krishna Vishwa Vidyapeeth, deemed to be University, Karad.
I now invite Dr. Prakash Narikal sir to present an overview on launch and orientation of the Doctor of Nursing Practice Critical Care Program.
Good evening, esteemed dignitaries on the dais. Honorable Dr. Neelam Mishra, Vice Chancellor, Krishna Vishwa Vidyapeeth, deemed to be University, KUD Karat. Honorable Dr. T. Dilip Kumar, President, Indian Nursing Council, New Delhi. Dr. M.E. Gorpade, Registrar, KUD Karat. Dr. Vaishali Rasing Moite, Dean, Krishna Institute of Nursing Sciences, Karat. And the distinguished dignitaries from the Indian Nursing Council, university officials, Chief Nursing Officer, faculty members. It is my pleasure and privilege to present an overview of today's historic event, the first time in India launch and orientation of the Doctor of Nursing Practice Critical Care Program, organized by the Indian Nursing Council in collaboration with Houston University College of Nursing, Texas, USA, and hosted by Krishna Vishwa Vidyapeeth, deemed to be University, Krishna Institute of Nursing Sciences, Karat. The event began with inaugural program at 9 a.m. The chief guest for the program was Honorable Dr. Suresh J. Bhosle, Chancellor, Krishna Vishwa Vidyapeeth, deemed to University, Karat, and the event was graced by the presence of Honorable Dr. T. Dilip Kumar, President, Indian Nursing Council, New Delhi, Dr. M.E. Gorpade, Registrar, Krishna Vishwa Vidyapeeth, Mr. P.D. John, Executive Director of Krishna Vishwa Vidyapeeth, Dr. Punita ma'am, Mrs. K.S. Bharti, Senior Consultant, INC, New Delhi, Dr. Pramila Lee, Professor, Christian Medical College, Vellore, Professor Shaini Varghese, Professor Dr. Beena Joseph, faculty from College of Nursing, University of Houston, Texas, USA, Dr. Asha Sharma, former Vice President, INC, Dr. Premila Lee, Professor, CMC, Vellore, Dr. Arjun Anevadkar, Medical Administrator, Krishna Hospital and Medical Research Center, Karad, and deans of other constituent faculties, university officials, medical preceptors, nurse preceptors, ICU in charges, faculty and students. The inaugural program commenced with an invocation song by students of Krishna Institute of Nursing Sciences, Karat, followed by the traditional lamp lighting ceremony by the dignitaries on the dais, symbolizing the illumination of knowledge and the beginning of new academic journey of DNP students in the India. This was followed by a floral welcome and felicitation of dignitaries with the mementos to commemorate the historic moment. Dr. Vaishali Raj Singh Mohite delivered the welcome address and presented the journey of MSc Nursing in Nurse Practitioner Critical Care Program at King's Karat from 2017. She shared high insights into the conceptualization of the program, curriculum development, innovative teaching and learning strategies, the challenges faced, and how these challenges were overcome under the leadership and guidance of Honorable Dr. Suresh G. Bhosle, Chancellor, KVD Karat, Indian Nursing Council, New Delhi, alongside support of university officials, medical preceptors, nurse preceptors. This provided the perfect context for the introduction of DNP critical care program. Followed by this, Honorable Dr. T. Dilip Kumar, President of Indian Nursing Council, officially launched the DNP critical care program. In his address, he emphasized the critical role this program will play in transforming nursing education and practice in India. He highlighted the importance of developing advanced nursing professionals who are capable of handling critical care situations and leading healthcare reform in the country. And also, sir mentioned about the Maharashtra showing light to the country, especially Krishna Vishwa Vidyapeeth in nursing education, and also expressed the efforts to start this DNP program, and also congratulated the Chancellor, sir, for starting this DME program at Karad. So, followed by President's speech, Professor Dr. Beena Joseph and Dr. Shaini Varghese from Houston University shared their experiences and emphasized the importance of global partnership in enhancing the quality of nursing education. They expressed their excitement about the DNP program's potential to uplift the Indian nursing standards and create a strong foundation in evidence-based practice. Why should all nursing professionals should opt for a DNP program? Dr. Asha Sharma, former Vice President INC, congratulated the university for starting first time DNP program and also provided an overview of the workshop objectives, outlining the sessions that would cover the implementation of evidence-based practice, quality improvement, research utilization. This set the tone for technical sessions that are going to be followed in workshop. And course mainly mentioning 85% of practice at clinical area and only 15% theoretical aspects. So it is going to be practical oriented course developing a professional leaders in the nursing practice. Honorable Dr. Suresh Bhosle, Chancellor KVD Karad, congratulated the organizers and welcomed the program. His speech focused on critical need for advanced nursing professionals, Indian healthcare, how the DNP program would play a key role in addressing this gap. Appreciated the role of INC in developing nursing education at Karat and India, and hospital known for nursing services and the importance of nursing in healthcare delivery system, and suggested for starting a course for nursing administration by the INC. The inaugural session concluded with vote of thanks by Dr. Jyoti Salanke, Professor and Dean Academics, Krishna Institute of Nursing Sciences, Karad. She expressed her gratitude to all the Indian Nursing Council members, the College of Nursing at Houston University, and all the dignitaries and participants for their active involvement in the program. The launch of the DNP Critical Care Program marked a momentous occasion, being the first of its kind in India. It signaled the start of a new era in Indian nursing education, opening up new opportunities for nursing professionals to pursue advanced education in critical care, aligning Indian nursing with global standards. The collaboration between INC and Western University promises to strengthen this initiative with ongoing support for development of skilled healthcare leaders. The event set stage for one-day workshop designed to equip participants with essential knowledge and skills to successfully implement the DNP curriculum and develop evidence-based practice projects. So followed by this, a tea break and workshop begin with the sessions mainly on overview of INC guidelines for starting DNP critical care by Mrs. K.S. Bharti, Senior Consultant, INC. Madam provided comprehensive briefing of Indian Nursing Council guidelines for establishing DNP programs in universities, colleges. She emphasized the importance of these programs in raising the professional standards of nursing education in India. She covered the regulatory requirements, accreditation process, and implementation of guidelines that institutions should follow. The second session was DNP curriculum overview by Dr. Punita ma'am. So, explained the curriculum framework for the DNP program developed in collaboration with Western University. She highlighted the core components such as clinical practice, leadership, health policy, evidence-based research, seminars, clinical hours, credit hours, theory hours. And session 3, DNP education and scope of practice in USA by Dr. Beena Joseph, professor from Houston University, provided insight into the journey of DNP practice in United States and discussed the essential skills required for critical care practitioners and how DNP graduates contribute to healthcare delivery by applying evidence-based solutions to improve patient care outcomes. Session also introduced the participant to the role of DNPs in shaping healthcare policies. Madam also explained domains and concept according to AACN. And a comparison of DNP with PhD programs in India and USA was also conducted by Madam. Then session 4, the quality improvement methods by Dr. Premila Lee. So session on a quality improvement, focusing on their importance in nursing factors from FME, then root cause analysis, benchmarking process, process mapping, clinical research area, service, evaluation, and clinical transformation with real practical examples of clinical practice. So followed by this, there was a lunch break, and after lunch break, session 5, that is evidence-based practice methods by Dr. Shani Varghese, covering history of EBP, then Sackett's 5-step models, purposes of EBP and quadruples, then components of EBP, and implementing the best evidence in patient care. And participants were guided on how to conduct literature searches using search engines like Sinal, then Picot model of evidence-based project. Then session 6, that is differentiation between EBP, quality improvement, and research utilization by Dr. Shani Varghese. Clarified the distinction between evidence-based practice, quality improvement initiatives, and research utilization in clinical practice. Participants how to each contributes to better health care but operates with different methodologies and goals. The session 7, that is scholarly EBP project, introduction and phases by Dr. Beena Joseph. Madam Beena Joseph explained about EBP project phases with examples, purpose, and EBP project starting from project site to sustainability. Madam also presented one EBP project which made every participant known to prepare an EBP project. The last session, that was EBP proposal and EBP report writing by Beena Joseph, explained how to prepare a EBP proposal to start with gap analysis and following Picot question method, IRB process, and also explained the parts of EBP proposal and format like BSW scholarly writing model and rules for writing also covered by the ma'am. And this workshop was a fruitful experience for all the future DNP and also nurse practitioners and faculty members. And by this I conclude my report. Thank you.
Thank you, sir. Now, I welcome Honorable Dr. Neelam Mishra Ma'am, Vice Chancellor, Krishna Vishwa Vidyapeeth Team to be University Karad, to hand over the certificates of today's event. Firstly, I would like to call upon Dr. T. Dilip Kumar, sir. Dr. Shiny Verghese. Dr. Punita Ma'am. Mrs. K.S. Bhardi Ma'am. Dr. Pramila Lee. Dr. Beena Joseph. Dr. Asha Sharma. Thank you, ma'am. Now I request Honorable Dr. T. Dilip Kumar, sir, President of INC, New Delhi, to hand over the certificate to one of the NPCC participants. One of you, please come forward. All of them can come forward and receive the certificate. All NPCC participants can come forward and receive the certificate. I invite Rohini Baba Ma'am, Chief Nursing Officer, to come forward and receive the award with the NPCC students. Thank you, everyone. Thank you, ma'am. Now, I would like to invite Suhas Nirmal to give a feedback of today's event.
Good evening all. Myself Suhas Nirmal, second year NPCC student. I would like to thank to our management and Dean ma'am for launching this orientation of DNP program. As we were early waited this moment, the speaker provided us useful and practical strategies to work as a competent nurse practitioner, and by today's workshop we came to know about the doctors of nursing practice in detail, how to translate research to bedside practices by evidence-based practices, and explain about scope of doctorate of nursing practice for the highest level of clinical practices, and leadership and a role of discipline to us, then quality improvement and the development of validation and advanced competencies in clinical area, where the in practices of PhD in research in intensive degrees, and this really helped to us in future for the more clinical evidence-based practice. And the workshop was very useful to us to know more about the DNP as well as advanced nursing practice. Thank you to all.
Thank you, Suhas. Now I request Dr. T. Dilip Kumar Sir, President of Indian Nursing Council, New Delhi, to address the gathering. Please come forward, sir.
Honorable Vice Chancellor, Madam, distinguished dignitaries on the dais and off the dais. Once again, I would like to congratulate all the nurse practitioners, candidates who really participated with a lot of enthusiasm. We could make out their participation was very interesting. And also I would like to congratulate the Krishna Institute of Vidyapeeth for taking the initiative of to become the #1 institution in India to start this DNP program. This itself shows how Krishna Institute of Vidyapeeth is want to take the forward the nursing education and nursing practice and also innovative programs, because it becomes very easy to run the regular program. I think an institution is taking interest to launch the new program and also to bring the global the nursing programs into India. So that is a big initiative which the Krishna Institute of Vidyapeeth has taken, and we as the Indian Nursing Council would like to support this initiative and to take forward. And also we would like to thank our partner from the University of Houston, Dr. Todd and Shelly Varghese and Joseph. I think with short notice they were able to make it convenient to participate, and they are really shown their interest. And they have brought how some of the new technologies, new evidence nursing practices which are prevalent in the United States, how they would like to bring it to the India. And again, this institution is in many ways in first. And another first is, I think you are our partners from the University of Houston coming all the way. They are being Indians, and they have, because many times we always some of the new programs are launched by the other foreign dignitaries, whereas a new initiative and a new one of the highest degree which India nursing fraternity can think of is the DNP, and such program is in the hands of our Indian nursing professionals, which they have excelled in the United States, and they were able to come back to and to give their what they have excelled in from the in the USA, and they want to see our Indian nursing and midwifery professional also to reach that stage. I think that's once again I would like to remember on this occasion the Dr. Durga Agarwal, who was the man behind to bring this DNP program to India, and also is the man behind being an engineer from India, working in the Texas, and he has contributed for the, I can say, world nursing and midwifery sector, because the Texas itself was not having the DNP program. His initiative of taking forward in the University of Houston, which has now they could start the DNP program in University of Texas, and the same he wanted, he being an Indian and going and successfully flourishing the business in the United States, he wanted to give back to India, especially in nursing and midwifery, because you don't know how much follow-up work he has done, and how many telephone calls, how many monitoring with the University of Houston and with the Government of India and also with the Indian Nursing Council. That speaks volume of his interest. And today we have seen the light of the day of launching this program on a pilot basis, and the Krishna Institute of Vidyapeeth is going in the history of the nursing and midwifery in India. And definitely this new program is going to see that how best we can improve the quality of the nursing practice, because generally we always talk of the PhD program where in the education excelling, but whereas this is the innovative idea of how best the nursing practice, nursing and midwifery professional working at the bedside, working in the critical care, how they can excel themselves to contribute for the providing the competitive and comprehensive patient care, to see that the impact and outcomes can be seen in the critical care units. So I think the nurse practitioners who have participated in this, I think I would like to congratulate all of you. I think many a times what happens as a students, they don't want to venture into the new programs. You have taken the so much decision and the interest to take this new program, to be the first ones in India. That speaks volume of interest of being the first nurse practitioner program in these institutions. So your names are going to be in the history of the nursing and midwifery in India. So therefore, I once again I would like to congratulate the people who work behind the screen to make this program, and especially our Vellore, our nursing and midwifery professional like Dr. Punita and the Pramila, who have taken a lot of interest to make this program successful. Again, my team in the Indian Nursing Council, Dr. Asha Sharma, Bharti, and our secretary, Colonel Sarvajit Kaur, and all these people work behind the screen to take forward and to launch this program on a pilot basis. I think everybody needs to be congratulated, because many a times it's anything new program, lot of work has to go behind the screen to make this program successful. So I think it should be written in the red letter of the day for the nursing and midwifery sector in India. So once again I would like to congratulate all of you and thank you very much. And definitely Indian Nursing Council is going to provide all technical support, not that only we are going to be only by launching. Definitely we will be issuing a guidelines to the institution, how best you can collaborate with the University of Houston to take forward this initiative to make it successful. And definitely we may face some of the hiccups. Definitely we will try to solve those hiccups and see that this program should not only to be limited to this institution, this again it should go to the many of the institutions, because critical care is one of the very important area where we can the nurses participation can reduce the impact can be made for the critical care patients. So therefore this is a new beginning and new career path which has shown for the nurse practitioners in India. Once again, wish you best of luck. Thank you very much.
Thank you, sir, for those kind words. Next, we would like to invite Honorable Dr. Mrs. Neelam Mishra Ma'am, Vice Chancellor, Krishna Vishwa Vidyapeeth, deemed to be University Karat, our innovative visionary, to enlighten the gathering.
Respected dignitaries on and off the dais, esteemed organizers and participants, ladies and gentlemen, my dear students, respected faculties, again very good evening to one and all. It is an absolute pleasure and privilege to stand before you in my humble capacity as a Vice Chancellor of this illustrious university. At this valedictory function of ceremonial launch specialty programs in the Faculty of Nursing of novel and unique type, which turns out to be a maiden launch in the country, bringing real credit and glory to the Krishna Institute of Nursing Sciences. I would like to record my sincere thanks of thankfulness and gratitude to all the key luminaries who not only graced the inaugural ceremony but also have guided all concerned by their words of wisdom in an immaculate manner. Their advice, counsel, guidance, university we shall always not only uphold, but also look upon so that for timely extension of the same whenever it is needed. I shall be failing in my duty if I am not complimenting Dr. Vaishali Mohite Madam, Dean of illustrious institution, and her team for not only picking up challenges but also mitigating them in an impressive manner by adding feathers of credit to the cap of our university. The present initiative, in my humble opinion, could not only result in expansion of academic, but also is providing for an advanced path for turning them into nursing practitioners in specialized domains. It is pertinent to note that the paucity of nursing manpower in India and in the entire developing world is a huge challenge. The mitigation of the same, not only in numbers but also in required cadre, including those of specialty domain, is the only way for the purposes of making health an equitable right to all concerned across the globe. This will mandate the policy interventions, academic initiatives, and all support mechanisms to be rendered in the required cause of generation of trained nursing manpower in the desired and required manner in the shortest possible duration, so as to make healthcare services meaningful, impactful, and capable of fulfilling the absolute needs of global population at large. The initiative so taken by the university through its nursing unit, in my humble opinion, is a landmark in that direction which I could like to salute in all my humility. I am sure that the team led by Dr. Mrs. Mohite would left no stone unturned to make it grow and develop, that it turns out to be an exemplary model in the country as a whole, worthy of emulation. On this valedictory, I only like to put across my sentiments as brought out by Swami Vivekananda when he said, "Arise, awake, and stop not until the goal is achieved. Let us live the same." Thank you very much. Jai Hind.
Thank you, ma'am. As we come to the conclusion of our event, I would like to invite Dr. Mrs. Nutan Potar, Associate Professor, Krishna Institute of Nursing Sciences, Karad, to propose the vote of thanks.
First of all, I would like to thank to our principal madam for giving me opportunity to give vote of thanks. Good evening, good evening to all the esteemed guests, dignitaries, and participants. I extend our deepest gratitude to our chief guest for the valedictory session, Honorable Dr. Neelam Mishra, Vice Chancellor of Krishna Vishwa Vidyapeeth, for your inspiring presence and insightful address. Your leadership continues to guide our institution towards excellence, and we are deeply honored by your presence. Thank you, madam. We are deeply grateful to our Honorable Dr. T. Dilip Kumar, President of Indian Nursing Council, for launching this prestigious DNP program. Your remarkable contributions to the advancement of nursing education in India are truly commendable, and your support has been crucial to the success of this initiative. Thank you, sir. A special thanks to Dr. M.U. Gorpade, Registrar of Krishna Vishwa Vidyapeeth. Your contribution have been pivotal in success of this event, and we deeply value your support. Thank you, sir. Special thanks to Dr. Asha Sharma, ex-Vice President, INC New Delhi, for your valuable insights that have enriched this program. Your contributions are much appreciated, and we are thankful for your support. Thank you, ma'am. We are also deeply grateful to Mrs. K.S. Bharti, Senior Consultant of the Indian Nursing Council, for your participation and support. Your involvement has been essential to the smooth execution of this event. A special mention of appreciation goes to Dr. Beena Joseph and Dr. Shaini Varghese, faculty members from the University of Houston. Your contributions to this collaboration have been invaluable and we are grateful for your insights and partnership in strengthening the ties between our institutions. Our heartfelt thanks also goes to Dr. Punita Ma'am, consultant at the Indian Nursing Council, for your esteemed presence and valuable contributions. Your experience has added immense value to the discussion and the overall discussion of this event. We are also deeply grateful to Dr. Pramila Lee, Professor at Christian Medical College, Vellore, for your leadership and contributions. Your presence continues to inspire and uplift the nursing community. A special thanks goes to our Dean, Dr. Vaishali Mohite, for your leadership in the NPCC program. Your dedication and vision have been instrumental in advancing the program, and we deeply appreciate your efforts. Thank you, Madam. I am also thankful to Mrs. Rohini Babar, Chief Nursing Officer, Krishna Hospital, Karad, Dean and Dean Academics of various faculties of KVV Karad. I would like to acknowledge the dedicated efforts of our medical preceptors, nurse preceptors, and ICU in charges for their mentorship and guidance. I would also like to express our gratitude to the photography department, IT department, and guest house staff for their cooperating and support throughout the event. Finally, I extend my deepest thanks to teaching and non-teaching staff of KINS, whose tireless efforts and hard work behind the scene have been essential to making this event success. Thank you, one and all. Thank you.
Thank you, Nudan ma'am. Esteemed guests, faculty members, and our beloved students, with absolute pleasure, we welcome you to the closing ceremony of the Doctor of Nursing Practice program launch. It has been an eventful day of inspiration, learning, and celebration. We are thrilled to be embarking on this new journey towards advancing nursing leadership, clinical excellence, and patient care. Today's event has been a momentous occasion, marking the official launch of a program designed to empower nursing professionals to make a transformative impact in healthcare. Through today's discussions and presentation, we heard about the vision, challenges, and the opportunity that this new chapter will bring. As we close today's ceremony, I would like to extend our deepest gratitude to all who made this event possible, our faculty, administration, and especially our beloved students, who are the heart of this program. You are the leaders and innovators of tomorrow, and we are confident that the knowledge and skill you gain from this DNP program will serve to revolutionize healthcare for years to come. With that, we officially declare the Doctor of Nursing program launched. We invite everyone to stay connected and continue to share in this journey together. Thank you for your participation, and we wish you all a continued success. Thank you once again. Now requesting all to raise for the national anthem.
Sindhu